Well, thank you so much for inviting me to speak to you this afternoon. I want to preface my remarks by letting you know that I'm not our primary expert in this area. We have a couple people on our staff who really are digging into these issues, and of course both of them were on vacation today, so I graciously agreed to do my best to represent this issue area. But we do have a lot of interest in the area, a lot of research that we've sponsored, and if there are questions that I can't answer, I will take them back to our real experts, and we'll do my best to follow up with answers. So of course we don't like to just use this phrase dual eligibles to the general public, because most people is like, what's that? So just to be very basic, these are people who are eligible for both Medicare and Medicaid. And of course, many people in the general public don't really even have a good idea what these two programs are, what the difference between these two programs are, and so forth. So it's a complicated, complex area. But within this broad area of people who are eligible for both Medicare and Medicaid, a primary area of interest is on long-term services and supports, otherwise known as long-term care. In part, there's a demographic reality. We are getting older. The boomer cohort, which is the largest population cohort I think our nation has ever seen, is hitting that 65 plus age group now, and over the next 20 years will be aging into the group that is most likely to need long-term care services. And so with looking at what costs money in the system, because of course everybody is concerned about high costs, it's been very apparent for quite some time that this population that's dually eligible is a very high-cost, vulnerable population, in large part because they are the most likely to need long-term services and supports, and either to have been low income throughout their lives or to have spent down to low income as a result of high health or long-term services costs. So just the economics of it makes this a really important area and one that is very ripe for innovation. So how many of these people are there? There's about 10.2 million people who are eligible for both Medicare and Medicaid, but not all of them get the full package of Medicaid benefits. Those who get the full, what we call the full duals, are about 7.4 million, and that other almost 3 million are people who get the income support in paying for some of their Medicare co-payments, what we call the QIMBYs and the SLIMBYs, and so they don't get the full package of Medicaid benefits. Their incomes are sort of in the middle, and this discussion is really going to focus on the full duals, the people who are eligible for the whole shebang. So as I mentioned, they are the poorest and the sickest of all Medicare beneficiaries. Not only are they more likely to need long-term services and supports, they are more likely to have multiple chronic conditions, cognitive impairments, other functional limitations than the Medicare beneficiaries who are not also on Medicaid. That said, they are by no means a homogeneous group. Now this isn't showing up very well, but the Congressional Budget Office very recently, this just came out in this month, June of 2013, did a report on the characteristics of this population group. And so the statistics that are about to follow are from this brand new analysis by the Congressional Budget Office. So about 4 in 10 of these dual eligibles are under the age of 65. So these are people, you know, often we don't think about the younger Medicare population, but there are people who have disabilities who are able to qualify for Medicare. They may have had a work history and then become disabled as adults and therefore are qualifying for Medicare. But then 6 in 10 are over the age of 65. They are about twice as likely to have 3 or more chronic conditions. So when I say chronic conditions, that means perhaps something like diabetes, high blood pressure, conditions that really there's no cure for, there's an ongoing need for medical services. And they're 3 times as likely to have a mental illness, which also is associated with a very high need for supportive services. So of these full duals, about 20% have 3 or more chronic conditions, 30% have been diagnosed with a mental illness, and 44% receive long-term services and supports. So it's kind of interesting that not all of them are getting long-term care. Many of them just are very sick. They may have, heart disease, something that just really is a costly ongoing medical expense, but a substantial proportion of them are getting long-term services and supports, which of course are provided through Medicaid because Medicare doesn't cover those services. So I mentioned that this is a very high-cost population. You can see from the numbers here, I hope you can see, that the dual eligible population accounts for a disproportionate share of both Medicare and of Medicaid spending. So if you look at this, this is average per beneficiary spending in 2009, which was the most recent year that we had data for. The full duals, Medicaid is spending about $15,000, Medicare about $18,000, for a total cost of over $33,000 a year. And the Medicare beneficiaries who do not participate in Medicaid as well, you can see the Medicare cost is less than half the amount of the Medicare cost for the dual eligible. So this is a population, they're sick, and their illnesses cost a lot of money. So the way the system works, it's very difficult to coordinate between these 2 systems that really don't interface in a seamless kind of way. Medicare, of course, is a national program. Medicaid is a partnership between the federal government and the states, with each state crafting its own program. So Medicare is the primary payer for acute care, post-acute care, chronic health care, and so forth. Medicaid is the primary payer for long-term services and supports, and for cost sharing that other Medicare beneficiaries have to pay either out of pocket or by having a supplemental policy. So because these people are enrolled in 2 separate programs, they have to navigate 2 different systems of care that have different rules. They don't understand, if you're a consumer, if you just, go and you're found eligible for these programs, you don't necessarily know what's covered by Medicare, what's covered by Medicaid, who you have to talk to get a service authorized, and so forth. So there's a lot of confusion, there's a lot of fragmentation. Quite honestly, either system alone can be difficult and confusing for consumers, and put the 2 together and it can be a real quagmire. So in recognition of the fragmentation, the need to coordinate, there are now a host of new efforts to better integrate Medicare and Medicaid to coordinate care for the dual eligibles. So some of the issues that have been identified, what is it that needs to change to make the system better? So CMS has been a leader in this area. Many states are interested in improving their systems, and advocates also are focusing in this area to have better care coordination, more harmony between the 2 programs so that the rules are a bit more consistent. Access, obviously, to a high-quality continuum of care that includes primary care, behavioral health care, long-term services, everything that the person needs really to stay as healthy and functional as possible. More efficient care in terms of the cost and delivery of care, and then an improved experience of care for the beneficiaries and for their family caregivers, because these people with the high number of chronic conditions and functional impairments, very often there is a family member who is the one helping them to navigate the system, and it's equally frustrating for the family caregivers to try to navigate these systems. So there is expertise that's needed in order to figure out how to even change these systems, and the two systems don't always have the right sets of expertise. So for example, the Medicare system isn't necessarily well-versed to serve people who are frail with disabilities. It's focused on medical care, but not necessarily some of the functional needs. If you are a consumer who uses long-term services and supports, there's the need to balance safety and autonomy. So many people have, and probably people in this room, have had the experience perhaps with an older adult that you perhaps worry about living safely at home. You're thinking they're going to fall, they're going to leave the stove on, you know, and so forth. And so there's always the concern about safety, but at the same time, people, as they age, don't lose their desire to have as much autonomy as possible. And so there is this balancing act. You know, nobody wants to be unsafe, but on the other hand, most people don't want to go into a nursing home sometimes when a family member thinks they would be safer there. There also is this issue of blending both health services and social services. So of course the Medicaid program will provide things like assisted transportation, homemaker care, personal care, things that the Medicare system won't provide. So you need expertise in providing this continuum of services. Also the issue of engaging and supporting family caregivers. This is an issue that is very high priority for AARP because we recognize that the vast majority of long-term services and supports that people get is actually provided by their family members. And it's only when the person gets increasingly disabled and needs more help than the family can provide that people tend to then turn to the formal system or to Medicaid. There's also a need to measure both quality of life and quality of care. And we haven't advanced that far in really measuring, developing good measures of quality for home and community-based services. We have quality measures for nursing home care, we have quality measures for health care, we have quality measures for home health care, you know, things like how often is someone rehospitalized, you know, are they getting pressure sores and so forth. But in terms of that quality of life, is the person who is living independent able to meet their life goals and have the services delivered in the way that they're comfortable with? Are they able to have their home care worker perhaps come at the time of day that's their preference and so forth? And there just really aren't good, consistent across the state's measures of that kind of quality. And then the long-term services and supports workforce is one of the areas that not only the need is growing among the fastest of occupations in the US, but the projected shortages of home care workers is among the greatest area of potential shortages in the nation. So there's a real crisis coming there. All the more reason really to support the family caregivers who are providing services because often they can forestall the need to go outside and hire someone. So an Office of the Duals was created. This was part of the Affordable Care Act to create this Office of the Duals to try to come up with some innovative ways to coordinate services and so forth. And so the Office of the Duals is testing two different models. It's a little bit confusing, but one is a capitated model in which the state, CMS, and a health plan have a three-way contract where the plan receives a set payment from Medicaid and from Medicare, and in return they agree to provide the whole range of services that the individual needs for that capitated rate. The other model, which I believe it may be that only one state is actually looking at this model, is called managed fee for service. And this doesn't have a health plan in the picture. It has some other entity, which might be the Aging and Disability Resource Center or the Office on Aging, maybe some kind of nonprofit organization. This entity gets the payment to coordinate the care for the dual eligibles and to hopefully achieve some benchmarks for improved outcomes, like maybe fewer nursing home stays, fewer hospital visits, and so forth. And the example given there is that for a set fee, the care team or the care manager oversees the services delivered to these high-risk individuals, including specialists, behavioral health, long-term services, and so forth. So initially, 26 states submitted proposals to this Office of the Duals, and you can see there were 6 proposals, the dark red for the managed fee for service, 17, which is sort of that periwinkle color, for the capitated plans, and then 2 brave states, I guess, decided maybe they would try both models. That's just what was submitted, and then today, actually, the picture has changed, and the states in red have withdrawn the proposals they had submitted. There are 14 proposals pending. The yellow is a little hard to read, but the 6 yellow states have memoranda of understanding that are signed, and they'll begin implementing. So next I'm going to turn to, and this I believe was in your packets, a research report that was prepared by the Public Policy Institute in conjunction with Health Management Associates and NASHUAD, the National Association of States United for Aging and Disabilities. So we did a study interviewing officials from all of the states to find out what initiatives were they pursuing to serve this dually eligible population. And what we found is that quite a bit is going on, but not necessarily through that Office of the Duals. So you saw that a bunch of states started out with that approach, and they withdrew their applications in part because they decided that maybe it wasn't flexible enough to meet their needs, or there were too much paperwork, or so forth and so on. But there are many initiatives. I think it's probably in here. I think it's about 38 states actually are doing something to try to address this population. So most of them are looking at those full duals with the full spectrum of LTSS needs. Most of the initiatives are being implemented statewide, not just in an area of the state. Most of them are considering this risk-based managed care model as a hope for better coordination and better cost savings. And some states have initiatives that are outside of the CMS financial alignment demo. As I mentioned, 2/3 of the states that are doing things are actually outside of that Office of the Duals. Now, the reason it hasn't already, why this nut hasn't already been cracked and the problem solved, is that it's really difficult to do. It's a very complex system. These are people with complex needs. It's not easy. If it was easy, most of the states would have figured out how to do it by now. So some states have delayed implementation because they realize they need to study more, they need to get their ducks in a row. Some have dropped out of the CMS demo, as I mentioned, but are pursuing alternatives. So then, that's sort of from the governmental perspective. From the perspective of consumers, what is it that consumers want? Well, they want better care coordination. They want to be able to just go to one place and have their questions answered, be referred to the right providers, and so forth. Better transitions between care settings. So I suspect there are many people in the room today also who have experienced caring for a loved one who maybe has been in the hospital, and sometimes the really the terrible call is that, you know, Friday afternoon at 4 o'clock, you're told they're being discharged today, they need to find a skilled nursing facility, and good luck, you know, making the phone calls and trying to find that skilled nursing facility at 4 o'clock on a Friday afternoon. And I can tell you, I went through this just several months ago with my stepfather, who was vacationing down in Florida, fell, broke his hip, needed a hip replacement, needed to be airlifted out of the Everglades and so forth. And it was, let's just say, my mom was glad she had a daughter who worked at AARP and was an expert in long-term care to help, because otherwise, you know, she was just like, what do we do? So better transitions between the hospital, the nursing home, the home, and so forth. Families really need to be considered partners in care. If you are the person who has a disability, especially if there is cognitive impairment, there has to be someone else there helping. And so the care system really needs to acknowledge the role of family members and not have them have their needs disregarded. And then there need to be new options to provide services. So we often talk about person-centered care or person and family-centered care, where a care plan is developed to look at the needs of the individual, and rather than chopping up that individual into, well, they have a heart problem, so they need a cardiologist, and then there's their kidneys, so they need a nephrologist, and then they have a vision problem, so we'll send them to the ophthalmologist. We need someone who's going to coordinate. The problem that also many people have probably observed is different physicians prescribing different medications, no one overseeing how they interact, and that's how you end up getting somebody in the hospital with, you know, as many as 12 or so medications, and then someone in the hospital decides to change them all, and everything goes kaflooey, and clearly a need for better coordination of pharmacological interventions is really important. We need incentives that support the preferences of the individual to stay in a community-based setting and not automatically send them into a nursing home, because that's what Medicaid will pay for. And so incentives that support the ability of states to provide home and community-based services, and that can be difficult in part because people need housing options, and affordable and accessible housing isn't often available, especially if someone can't stay in their own home maybe anymore, but there could be another community option. They may need transportation if they're no longer able to drive, and so forth. So consumers need to be involved every step of the way. Consumers also need to be educated. They need to have unbiased information about what their options are. And there need to be transition plans, so there's no abrupt termination of relationships that people may have built over many years with their providers. So as states are going into these capitated managed care programs, AARP has advocated that there be some way to transition the providers. You know, it's not always going to be possible that every provider will be in the network. That probably isn't reasonable, but at least to give people time to transition. So if they've been going to a primary care doc for 30, 40 years, you know, give them some time to find a new provider that they're comfortable with. Transparency, consumers need to be able to make choices based on information they receive from uninterested or disinterested parties, so not to get a sales pitch from different providers, but really to be able to get neutral information about if they enroll in one plan versus another plan, what services will be covered, where are the locations, and so forth. And then, of course, continuity, so that it's not disruptive as people are brought into these integrated systems. So I mentioned that AARP has been very active in this area. I touched base with our state affairs staff before putting this together, and they let me know that in 2012, last year, 20 AARP state offices submitted 33 comment letters on various state dual demonstration programs. They have served on advisory committees. They've commented on proposed contract language, met with state officials, maybe even some of you, and so forth. So the bottom line is that the governmental entities are in the beginning stages of trying to see what will work best to provide high quality care to a population with very complex needs at the best cost, because everybody wants to save resources. Long-term services and supports has to be part of the equation if we're going to get costs down for this very high-risk population. And we're hoping that out of all of this sort of churning of ideas and options and innovative demonstrations, that new innovations will emerge, and that states can perhaps learn from each other what has been successful. And of course, the bottom line of the bottom line is that the health and well-being of very vulnerable consumers is what's at stake. So I can't go anywhere without talking about a major project of the Public Policy Institute in conjunction with two foundations, the SCAN Foundation and the Commonwealth Fund, that helped us to make this long-term services and support scorecard that came out in September of 2011, in which we undertook the bold task of ranking the states on their LTSS systems across a broad range of different indicators from the point of view of the consumer. And so if you can look at this little graphic, what we did was we developed a model of what a high-performing long-term services and support system would look like. And we said that there were 5 characteristics that it would have. There would be affordability of services and access of services. There would be choice of both setting of services and provider. There would be high quality of life as well as quality of care. There would be support for family caregivers, and there would be effective transitions and organization of care across these different delivery systems. So in the 2011 scorecard, we were not able to get enough data to populate that 5th dimension, the effective transitions and coordination of care, which really is what I was talking about earlier with these duals demos and so forth. So the first scorecard ranked the states just on these first 4 areas. However, we are deep into the process of doing an update, which will be out in 1 year, actually in June of 2014. And we are gathering data. We have data that we will be using to begin to populate that 5th dimension, as well as to show change over time on the indicators that we measured in the first scorecard. So I did bring 1 copy of the scorecard, which I'd be happy to leave with someone, and anyone who wants it, just let me know. We will send out hard copy, but you also can use the website, which has a host of wonderful features, and there across the top is it has its own web address, longtermscorecard.org, and on the website you can get the full report, you can get the executive summary. The chart pack is all of the graphics in the report, which you can download into a PowerPoint or just print them out. There is a fact sheet for every state that has the results, the overall ranking, the ranking on each of the 4 dimensions, and then there's a total of 25 separate indicators, and you get the score on each of those indicators, and then how it compared to the average score and how it compared to the score that was ranked the highest. I have this arrow pointing to the state-by-state interactive comparisons. It is really, really easy to use. If you go onto, it's a little bit hard to see there, but on the page that you would get when you go onto the website, sort of in the middle on the right, there's a little pull-down box where you can enter the state name, and then you can choose any of the 25 indicators that we measured, and then you can check boxes of any states that you want to compare with. So maybe there's a little bit of a regional competitiveness, maybe, if you're in Iowa, you want to compare with Indiana or whatever. You can check whatever boxes you want, and it'll pull up with just one click. It'll make a bar graph, and it'll show you how you compare with those other states. And then you check one more box, and it'll show you the worst state and the best state. And you can actually print it out into a PowerPoint just like that. And we, we haven't, prevented people from doing that. We really would love anyone to use that website, use the materials. That's what they're there for. So that ends my formal presentation, and I just want to point out that's my email address. You can certainly contact me directly if you have any questions. We also are a little bit late at AARP, but we are moving into the world of social media, so you can find us on Twitter at AARP Policy, also on Facebook. And then there's a link here, and I don't know, did people get a printout of the PowerPoint? Okay, so you have it. So that's a link. If you would like to receive materials from the AARP Public Policy Institute, and we put out hundreds of reports every year, not just in health and long-term care, but on economics issues, on consumer issues, and so forth. And many of our reports have state-level data. So if you would like to be added to our email list to get those reports, this is a link that will take you to the sign-up page.